In this presentation, I'll cover the management of hip displacement in children with cerebral palsy. I have no disclosures of financial relationships, but I will discuss the off-label use of botulinum toxin for hip spasticity. As you know, botulinum toxin has a long history of use in spasticity conditions in children, but it is an off-label use. When we think about an algorithm for hip displacement management, we should think about treatment dose, with the lower dose used for those children with less problems. For those children who have a hip displacement of less than 30%, a migration percentage under 30%, range of motion, postural treatment, and tone management may be options. The evidence for range of motion and postural treatment in terms of changing the natural history of hip displacement is relatively weak. But that is not to say range of motion and postural treatment are not important for these children for other reasons. Range of motion treatment helps overall function and, importantly, can identify the tightening of the hip musculature that's a risk factor for the hip displacement. There's some small retrospective studies that showed preservation of motion in children classified as GMFCS3 with spastic diplegia. Postural treatment with standing frames as well as supine sleeping frames can improve overall motion as well. And again, these are small retrospective studies that showed modest treatment effect in marginal and non-ambulatory children. I've listed the various studies here, and you should feel free to check them out and draw your own conclusions. What's important, though, is that we don't stop doing hip surveillance in children who have these treatments done as part of their treatment plan. When botulinum toxin plus bracing is used, unfortunately, it did also not stop the progression of hip displacement. This was a multi-center randomized controlled trial in Australia with 46 children who were followed for 10 years. In the non-treatment group, they were just followed over time with serial x-rays. In the treatment group, they continued to have serial hip surveillance x-rays, but they obtained botulinum toxin A in the adductors and hamstrings every 6 months and were placed into a sitting, walking, and standing hip orthosis or a swash orthosis for at least 6 hours a day. At final follow-up, there was unfortunately no difference between the groups in final hip morphology, the need for surgery, or the type of surgery that was needed. Now, the importance here is that although some of these modalities may be used for children leading up to surgery, they should not dissuade us from continuing to enroll these children in a hip surveillance program. Once the migration percentage has gone over 40 to 50% and the child is younger, preventative surgery is an option. Preventative surgery consists of adductor and psoas tendon lengthenings, sometimes proximal gracilis or proximal hamstring lengthenings as well. And the indications here are a migration percentage that's greater than 40 to 50% in a younger child, usually less than 4 to 5 years of age, with minimal acetabular changes. The goal of surgery is to improve static range of motion, to balance forces across the hip, and create concentric reduction of the femoral head in the acetabulum to facilitate proper hip development. It's very important that the surgery is done by somebody who understands the GMFCS level of the child, because overly aggressive hip surgery, hip soft tissue surgery done in a child who will later be ambulatory can create very bad gait disturbances, particularly if there's overly aggressive adductor releases or psoas releases or damage to the anterior branch of the obturator nerve. All of these can lead to an adductor insufficiency gait, which is very, very difficult to recover from. The outcome of these hip tendon lengthening surgeries depend upon the GMFCS level. As you can see from this chart, the GMFCS score was predictive of failure. GMFCS level 2 children, these are children who are ambulatory but have some difficulty on uneven surfaces, but do not use a handheld device had a success rate of 94%. Children who used handheld devices for ambulation, those who were GMFCS level 3, had a 50% success rate. Those who were GMFCS 4s and 5s had between a 15 to 30% rate of success. Now, you can look at this data and say that there are no benefits to the soft tissue release in those at GMFCS level 3 through 5, but I think that would be the wrong conclusion to draw. The benefits of the soft tissue release are that they improve motion, and that even though these children may need surgeries in the future to keep their hips in socket, it prevented the need for that surgery in many children. And in those that did progress, it delays the need for surgery until the children are bigger, and the surgery would at that point be safer and easier. The reason why hip tendon lengthening surgery alone does not work is that there are skeletal changes in children with neuromuscular hip dysplasia. All of us are born with a high neck shaft angle and quite a bit of femoral anteversion, but with functional ambulation over time, our skeleton will remodel. In children with neuromuscular hip dysplasia, this remodeling does not occur efficiently, and so they continue to have a high neck shaft angle, as you can see in the red, compared with what should be in the blue. As this progresses, they can have asymmetric growth of the femoral head, or caput valgum. Their femoral head starts to literally bend outside of the socket, as you can see in red, compared with the blue as the normal. Their acetabulum will also remodel so that it's upsloping, unlike the downsloping blue that it should be. And there's quite a bit of rotation of the femur that does not remodel, femoral anteversion. For all of these deformities, reconstructive surgery is required. And this is indicated in children with a migration percentage over 50%, generally with an age that's greater than 5 years. And we can even operate on children with hip dislocations, but I generally reserve that for dislocations that are less than 1 year, ideally, sometimes as much as 2 years. The goal of these reconstructive surgeries, these are pelvic and femoral osteotomies, are to reorient the bony anatomy to balance the muscle forces to achieve concentric reduction. In ambulatory children, seen in green here, we try to create physiologic congruity. That is, we try to bring their neck shaft angle down to a physiologic level, maybe around 125 or so, and reorient the acetabulum so that it covers the femoral head better, as seen in the example here. In children who are non-ambulatory, they generally have more displacement, and they tend to remodel their the results of the surgery, and so we try to over-contain them. We bring a femoral neck shaft angle down to maybe about 100 to 110, and we do more pelvic osteotomies to make sure that the femoral head stays within the socket with growth. Pelvic osteotomies in young children involve a single cut in the pelvis that allows us to bend the pelvis down to better cover the femoral head, as you can see in this sequence of imaging. We sometimes will use the bone graft from the femoral osteotomy and plug that into the space created by the osteotomy in the pelvis. That's shown here. As you can see, the bone graft is used in the pelvic cut. It can also be harvested from the iliac crest, and it's inherently stable, so no internal fixation is required on the pelvis side. This is generally referred to as a Degas pelvic osteotomy. The outcomes of this reconstructive surgery can be very good. As you can see here, the outcomes on CP child initially fall, as you would expect in the postoperative period at 6 weeks, but then climb to levels that are higher than what was there previously, showing that reconstructive surgery improves outcome in children. The survivorship of this reconstructive surgery is much better than the soft tissue surgery. Once children are adolescents, the reconstructive surgery can be more complex. The reorientation osteotomy in a more mature child would involve cuts that would free the acetabulum from the pelvis, allowing for free rotation, as seen here. in this example of a triple pelvic innominate osteotomy. If the head is not round, as in this child, a Chiari osteotomy with a shelf procedure is required. This creates a shelf of bone above the capsule, creating a good option for pain relief in these children who have hips that are not reconstructible in the standard way. Unfortunately, we need to have a treatment algorithm for children whose hips have been dislocated and have significant pain and are not candidates for reconstructive surgery. These are candidates for salvage surgery. These are children whose migration percentage is over 100%, that is, the hips are dislocated. They're non-ambulatory, have intractable pain, and have a dislocation that has been present for more than 2 years. And the reason why the dislocation should be present for more than 2 years is that these children will generally have a significant amount of arthritis and cartilage loss. And this causes severe hip pain that can interfere with care and hygiene. The goals of this surgery are to facilitate motion and to help with pain relief. The salvage surgeries come in 3 types: resections, reorientations, or replacements. When we resect at the subtrochanteric level, removing the lesser trochanter and all of the femoral head, and then tucking muscle over the top of the cut end of the femur. In reorientation surgeries, the femoral head is placed deliberately further away from the pelvis, and implants are used to help with healing at the osteotomy. This can be combined with the resection of the femoral head as well. Finally, replacement options are also present. These can be total hip replacements or hemiarthroplasties of the shoulder. All of these 3 options give some pain relief, but have different complications. Resections have the complication of heterotopic ossification, or bone that grows within the muscle, causing pain. Reorientation osteotomies have prominence of implants. And finally, replacement surgeries have a risk of redislocation. Notice here that I did not put fusion as an option, as studies have shown that this is a very bad option for children with cerebral palsy. Unfortunately, none of these options is as good as a located hip, because a hip that is in socket will function the best, have the best range of motion, and the least amount of pain. For these reasons, we think that hip surveillance is so important to catch these children early so that we're able to do more effective treatment earlier so that they can have better function and less pain throughout their life. Thanks so much for your attention, and feel free to email me with any questions.